We're live. Yeah, just in case somebody. Yeah, I mean, you guys can both do both of them. Okay.
I don't think so.
One of them is about convene, you know, like that one.
Yeah.
Really have a lot of
Yeah,
like you said, you know. Like you said, you know, because it seems like but our, you know, the I'm not real right. And let's see. You know what I mean? And usually, like, that this is an opportunity for them to see what it is that they love and They have that required test. You're like, I'm being less efficient because I'm going there.
I'm not with Mission Road Ministries. I'm gonna say hello again too. How are you doing? Yeah, yesterday. I was like, I need your thoughts and ideas because I realized that it's a world for me. Day to day, I know what I want from it. So I'm like, what model do y'all use? Yeah. Oh yeah. Yeah. So we chatted yesterday.
He asked.
Oh, yeah. I felt
They had one person, but they only have one person, and they're already doing it. It is very fast, and you can control it.
Yeah. I'm excited.
We can.
can't turn them on. And all you gotta do is power.
Yeah.
I like that. That's
Yeah, I want to get like the screen, full screen. That would be cool.
well, I'm sorry you had to be.
Hi everyone, we're going to get started in 2 minutes, so if you have to use the restroom, go ahead and do that. There's coffee and pastries, but we'll get started in 2 minutes. I don't like it.
Oh, but it's like he knew what was coming. Okay. We didn't.
Hi, Ethan.
Basically, less restrictive. Whatever's on paper. Just, no, but yeah. You mentioned it. Laura. I was like,
All right, good morning, everyone. Has everybody had a chance to grab some coffee or their beverage of choice? Get seated here. And I want to make sure I'm not creating feedback. All right, we will go ahead and get started. I want to welcome all of you today. I am Mary Garr. I have the privilege of being the President and Chief Executive Officer at Family Service Association. We are a 122-year-old nonprofit deeply rooted here in San Antonio and Bexar County. Our work is all about, actually we serve across 14 counties in Texas. You can check our website to see all the stuff that we do. We work with many of you as partners in our work here in Texas, and so appreciate you all being here. Our work is all about addressing those underlying barriers in individuals, children's, families, older adults' lives that really affect their long-term health outcomes and their life potential, as many of you do as well. And as you know, we cannot do this alone. We all have to come together with our various strengths. Is this working? Okay, good. And talents here to ensure that we are helping to make transformative, sustainable change in the lives of those we serve. Too often, we get bogged down in just trying to address making sure that people have food on their table today and a roof over their head tonight. And then it becomes hard and overwhelming and frustrating to figure out why we can't move the needle longer term. So we've got to find ways to break down our respective silos, even though they're, we don't intend to have them, but how do we break them down and work across sectors to understand that each one of us in our work, in our home, in our schools, and everything that we do, we affect health at its very core. We love to say that our docs and nurses, hospitals, clinics, etc., they're the ones out there influencing our health and fixing our health when we need help, and they do. I can tell you, I so appreciate my health care. But at the same time, health happens where we spend our time. Health happens in our homes. Health happens in our workplace, in our schools, and where our kids are spending time out of school. So those folks that are in any of those places, they are influenced by those environments. And so through that, all of us have to understand what is influencing health for our children, for our parents, for our caregivers, for ourselves out there, and what do we do if we really want to reduce rates of cancer and heart disease and mental health disease and diabetes and obesity. And diabetes is a real word, by the way. So understanding all of that, because all of that traces back to where we are born and raised, what opportunities we have in life, what barriers we have in life, and that goes back to social determinants of health or the non-medical drivers of health. You're going to hear from some amazing experts today, 2 wonderful local physicians here that you're going to hear from, and 3 experts from around the state of Texas. So you can see that it's not just a local problem. What we have is going around our country here. We are stronger together when we understand each other's perspectives and when we understand how work is going on around in other places, how it can help influence our decisions here, how we can work with folks locally and at other places as well. And we are so excited through that then to be able to offer you our 2nd annual conference here on the future of San Antonio, especially changing the long-term outcomes of our children by addressing these social determinants of health for future generations. Our partner on this here is Children at Risk. It's an amazing organization. If you don't know much about them, again, please check their website because they work out there on helping to shape policy, do advocacy, work with partners all around the state of Texas and beyond. They have the data that shows what's going on. You're going to hear some of that today on how that affects us. And then, the work that they have makes a difference for us at the local level. We help to support and inform them at theirs. So on that note, I want to introduce you to Dr. Bob Sanborn, who is the CEO of Children at Risk, leads an amazing team who works so hard on our behalf each and every day. And we're excited to have him and his team. And then, the rest of the panelists here with us today to talk with us. So thank you all so very much for being here. Think of what questions you have because they're going to be asking you for those shortly. Thank you.
Thank you, Mary. Big hand for Mary.
We are super excited to be working with Family Service. We love... Wow, that's intense. We love being in San Antonio, right? We find that this place, there's so much civic pride in San Antonio. It's a great city, and I'm always reminded it's the 7th largest city in the country, so I love that reminder always. And I love being on this campus, right? This is my first time on the Texas A&M campus here in San Antonio, so it's pretty exciting. I remember a number of years ago, I was at Rice University, I worked at Rice University, and I was invited to come speak at Texas A&M. in College Station. And someone said, all you have to do there when you're there is start off by saying howdy. So how many of you like have a background at Texas A&M, know a little bit about Texas A&M, a little bit, right? So, so I love that, you know, so howdy. Yeah, except when the room is full of Aggies, you get this resounding, really big howdy back, and it's really empowering for a speaker to hear this. Howdy. Howdy. Yeah, okay, still. But I love that idea so much. At Children at Risk, we do a thing where whenever we have a big gathering or small gathering, we say for children, and everyone yells back for children. So we can try that here. For children. For children. That's better, right? And what's interesting is when we do it, our staff, they're like, oh, Dr. Bob, you know, like but donors love it, right? And the board members, they really love the for children. And most people in the audience love for children. So, so we'll try for children. For children. There you go. Very good. Thank you, guys. So we do have a fantastic panel. And as Mary said, one of the things that we do at Children at Risk is we like to gather a lot of information from a lot of experts in communities, in the state, in the country, to really look at what are the best practices when it comes to our children, whether that's in education or in health, or in safety, or all the things that really contribute to the well-being of children, right? So we are focused on getting good information, best practices, looking at that data, making the data very accessible to the media, to the population, and to legislators, right? We spend a lot of time at the legislative level. And while we're nonpartisan, we are very political, right? Because we have to craft and frame those messages in the very unique political climate that we have in Texas, right? So we have to get people to understand it's not about politics, it's about our children. Unfortunately, on some issues, it becomes sort of knee-jerk political stuff, right? So we try to stay away from that and then reframe it again, and then really change things and try to change that system so that we have better outcomes for our children. So that's one of the things why we're excited to be here, is because it's another community in Texas that that we're working with, and working with Family Services is so fantastic because they have such an impact here in Dallas, holy cow, San Antonio. So let me introduce, I'm going to introduce our staff that are here from us. Christine is with us, and she's our data person. She's the director of our Center for Social Measurement and Evaluation. And then Nadia is with us from Dallas. That's where I was from, Dallas. So, but Christine lives here in San Antonio, Nadia's in Dallas, but we have staff all over the state of Texas. So we'll start with, I think we'll go ahead right into the data, Christine, if that's okay. So we'll go from there. The other thing that I want to mention is that at the state legislative level this year, we're finding for the first time that we're playing a lot of defense, right? And one of those areas is something that in Houston is very important for us. In the Valley, it's important, but it's increasingly important also in San Antonio and El Paso, is this idea of immigrant children, right? It used to be we could talk about what is in the state of Texas, about a third of our children are immigrants or children of immigrants. In Houston, it's about 50% of the children that are immigrants or children of immigrants. And it used to be we could talk about that pretty freely. And now it's becoming more and more difficult. And I feel like it's when we're talking about the future of our state, we should be able to talk about things pretty openly. So that's one of the things that there'll probably be some undercurrents today. There'll probably be some undercurrents around measles and vaccines. We'll talk a little bit about that today. And then what we probably won't talk about is about vouchers, but that's another undercurrent. That's a big thing at the state legislative level right now. But let's go into, Christine, let's go into some of the data, and we'll go from there. So, Christine, how are you doing today, by the way? So,
I'm great. Thank you. Yeah, so my name is Christine Thomas. I'm located here in San Antonio, and my passion is, overall well-being of children. I do have to give some biases. I am a child of an immigrant. And my daughter is here in San Antonio, local San Antonio. And so this data is really important to me. So thank you for letting me share this. So Mary gave some great overall things of what is the social determinant. So just kind of quickly, they're non-medical factors that influence health outcomes. So where we're born, where we're growing up, where we work, where we live, and where we age. So these determinants kind of encompass a wide range of factors such as socioeconomic status, education, neighborhood, and physical environment. and then these social supports within where we live. So when I'm talking about the San Antonio children, it's 500,000 children here in San Antonio. It's the 3rd largest population in the state, so we're important, right? We have this impact to kind of be these leaders of how our children are growing and their outcomes. So again, San Antonio is home to 7% of all children here in Texas. Race, ethnicity, majority of San Antonio children are, multi-ethnic, multicultural. 66% are of Hispanic Latino origin. 96% were born right here in the US. So again, it's a larger number than what we've seen in the past 10 years. Larger number of immigrant children. This is something we can't ignore. 30 different languages are spoken by San Antonio children, so it's not just Spanish. We have to have access to different services in multiple different languages. And then again, only 17% of public school students are EBEL, so that means emergent bilingual English language learners. I think that's kind of undermining. We speak a lot of languages at home, so again, we're not encompassing everything that our public schools are encompassing all the language that San Antonio children need.
I want to just go back a second, Christine. So one of the things that, when we talk about this percentage of Latino children in San Antonio, as you guys know, San Antonio is unique. I mean, a lot of the Latino children in San Antonio don't speak Spanish. That's different than a lot of the rest of the state. But I think what's really unique and fascinating about San Antonio is that San Antonio in many ways identifies as a Latino city. When you go to some other cities in Texas, other big cities in Texas, the majority of children always Latino in every one of the big cities in Texas. The majority of our children are Latino. But in Dallas, when you talk about race in Dallas, they think of it as black and white. They don't acknowledge that the majority of children are Latino in many ways. When you talk about Houston introduces itself as a very diverse city. They still don't say, but the majority is Latino. In Austin, you don't talk about the majority of children. You think of Austin as sort of a white town, right? But the majority of children, Latino. And so across the state, we can look to San Antonio sort of as the future of what's happening and the face of what's happening in terms of our children in Texas, because the vast majority in Texas of our children are Latino. Sometimes when I'll talk to Latino politicians, I'll say, oh, the majority, and they say, well, we like to have kids. And actually, that's not the answer, right? The answer is because Latino families are very young. White and African-American families are significantly older than Latino families. Young families have kids. So while the average may still be 1 or 2, the fact that Latino families are young means that's where the kids are happening, right? So it's sort of an interesting thing to look at this, though, because San Antonio then becomes sort of this way to look at what's happening in our state. So very interesting.
All right, we're gonna dive into mental health. So when we're thinking about...
Oh, okay, so before we do that, I want to talk a little bit more about that. The other thing, when we talk about, I thought there was another slide, so that's okay. So the other thing that I think is important is that when we're talking about social determinants of health, as researchers, one of the things that you can often tell very quickly, right, is that when you look at income levels of a neighborhood, the zip code that you're born in Texas especially, it's really a predictor of how you're going to do, right? So the level of income that your parents make, the educational attainment of your parents directly relates to how you're going to do as a child. And so we often will celebrate those children, like many of us here, that grew up in poverty, and we ended up doing well. We celebrate those people, right? All of us, we celebrate ourselves sometimes when we do this. But unfortunately, we shouldn't be part of a system that celebrates those that beat the odds. We should have a system that makes sure that every single child can be successful, right? And that's what we don't have, and that's what needs to change. Unfortunately, that gets caught up in a lot of things like, we're in Texas, you're pulling yourself up by your bootstraps. But as researchers, you begin to understand it's not just about, there's those kids that can't pull themselves up by their bootstraps and have parents that will help them do that, maybe. But how do we create a system that's going to work for us all? And so today, in a sense, we're going to be talking about how we work those systems. And as we look at this data, we have to understand that that's what it's all about. Creating a system where every single child, no matter what your zip code, that you're going to be able to be successful.
Thank you. And I know we're gonna be going into various topics. There's so many things that can encompass social determinants of health, and we're literally touching on only a few.
Yeah.
So talking about mental health here in San Antonio, this survey was completed by the city of San Antonio with their youth organization collecting this data. So survey was created and made for youth ages 12 through 19, and they showed that in San Antonio, 23% of the total teens reported ideas of self-harm. 25% of these teens reported suicidal ideation, and 52 teens did not know where to go when they needed help. So again, an access to where do you go, the first thing they go to is school, right? They're in these public schools. Unfortunately, the data is not on their side. So 411 students for every one counselor here in San Antonio. Recommended average is 250. So unfortunately, we're pretty far off on giving these kids access to things, that they go to really accessibly available at school. Texas is also failing at 360 students per every one counselor.
Yeah, I think this is interested nationally, right? That the recommendation is that for every 250 kids that there be a counselor. And that doesn't even take into account that at many schools in San Antonio, in Texas, counselors aren't even really doing counseling, right? They're busy doing administrative work. When the actual number is 411 kids for every counselor, and those counselors still aren't doing work, it becomes problematic. And historically in Texas, right, mental health has been completely underfunded, right? So we're 49th or 50th or 51st when you include Washington, D.C., and when you look at access to mental health. And historically what has happened in Texas is every time there's been a school shooting, we put more money into mental health because we don't want to really talk about guns. So we talk about mental health. And it's sort of like this sort of deal with the devil that mental health providers have made, like, okay, we'll talk about mental health as long as we get that money. After Uvalde, I remember that the governor promised a heavy investment in mental health in our state. And I remember someone said, so does that mean you're going to get Medicaid expanded so we can have all the money for mental health? And he said, no, we're going to find it somewhere else. We didn't find that money anywhere else, right? There was no big investment in mental health. There were some little investments, but no big investment. And what we're also seeing is that because after the pandemic, after shootings, there's much more trauma in the lives of kids than there has been in the past. The other thing that's interesting as we talk about Latino youth is that there's this thing called the Latino paradox when you look at data, where Latino kids can do a little bit better in certain things. But what we're seeing is that the data is really reflecting that mental health has become a significant concern for Latino kids. And so when you have 411 kids for every counselor, and those counselors aren't doing the work, that's sort of the front line where you should be taking care of mental health. And it's not happening. So we're going to see more and more of that unless we get that investment in mental health. And the other thing that we're seeing is superintendents around the state are figuring out, are there better ways to tackle mental health? And so there are groups like Communities in Schools and others that do an extraordinary job in terms of tackling mental health. And we're going to have to start looking at some of those best practices to make sure that our kids are getting some of the attention that they really need. Moreover, we passed a piece of legislation 2 sessions ago that allows for online counseling and for those counselors to be able to get reimbursed through any insurance kids have. So this doesn't necessarily need to be a burden on school districts for the counseling. They can get reimbursed through insurance. And so there are ways to get around this. We haven't been as creative as we need to sometimes when it comes to mental health, but there's more that we can do.
And Bob, just as a
Please,
reminder,
Mary.
as you all know in San Antonio, many of you, we have our San Antonio Mobile Mental Wellness Collaborative that some of you are partners in, so helping to address that need. And this came because kids in a public school district here in San Antonio made a cry to help at their school board. And so we have several nonprofits that have come together and we are providing services, but it is a drop in the bucket for what those are needed. So that is an example of nonprofits coming together. So it's family service, but it's also Rise Recovery. It has been the Convene endeavors. Communities in Schools was an early partner, but we also have had Children's Bereavement Center, et cetera. So
Yeah.
all of us have to work in this space, and we're working with children and mental health issues. And we have to find ways to partner with the schools who don't have the funds also to address these needs, let alone the staffing.
Exactly. Thank you so much, Mary. Very good.
All right, we are going to talk
Measles.
about measles. Yes, it sounds like a lot of people were familiar with this outbreak, so I'm just going to give an overview of measles and then we'll talk about our Texas data. So again, measles is extremely contagious. It's vaccine preventable. And it was officially declared eradicated in the US in 2000. That's amazing. Cases still occur due to unvaccinated travelers and then spread in under-immunized communities. So what are possible consequences of after you get the measles? Pneumonia, encephalitis, so swelling of the brain, and death. So it doesn't look, it says 1 every 1,000 gets swelling of the brain, 1 of every 20 children get pneumonia and can be hospitalized, and then 1 to 3 of every 1,000. And so looking at the data, so here in Texas, 81% of the confirmed measles cases in Texas are children. And there was 1 confirmed death of a child. So we haven't hit that 1,000 child mark yet, and we are seeing deaths. So we're seeing higher rates of hospitalizations here in Texas than what the research originally shows. So why is this happening? So Gaines County, where this outbreak did start, has a high measles vaccine exemption rate. So within, it's 18% for the whole county, with 1 district actually showing 80% exemption. So you can see the differences in Gaines, Bexar, Texas, and then the national average. Why should Bexar County be concerned? So we did see a decrease of this MMR vaccine rate, a decrease 9% this year. We're also seeing the same decrease across the state. So state of Texas is at risk for having bigger number of measles outbreak. That potentially means more deaths.
So a couple items on this that I think are worth noting. One is that we've seen a little bit in social media blame on immigrants for bringing measles in, right? And what I want to alert you to the facts is that in Central America and Mexico, the vaccination rates are significantly higher than in Texas, right? So I remember coming down, this is a number of years ago, where there was a lot of kids coming across. Remember that child surge that was coming across the border, and meeting with all the public health people, and everyone was saying these diseases were coming across, and the public health directors from each county were like, well, we have had 2 cases of lice. That was what was coming across the border, but media sort of was making a deal about it, and I think it's going to happen again. So that this idea that the vaccination rates are higher elsewhere, I think is important for us to know. The other thing that we're seeing is at the state legislative level, there's this big movement to say kids should be allowed to not be vaccinated. Parents should be able to decide whether kids should get vaccinated or not. We're seeing a lot more of that. You have to remember, in our country, there are about 2 million children that can't get vaccinated because of some autoimmune disease or some other type. So whenever we don't get vaccinated, it means that those 2 million kids are put at risk. The other thing that I worry about, which we don't talk about a lot, is that if we say vaccines are optional in our state, there's that group from Gaines County, right, that's just going to say, well, we're going to opt out. It's optional. We don't want it, right? But if it's optional, there's a whole group of moms and dads that are working really hard, that work hard to get their kids vaccinated because it's mandatory before school. If it's not mandatory and you're working hard and you don't have time, you're going to say, well, it's not mandatory anymore. Maybe I don't need to do it. And so I think about those moms and dads that just because it's not mandatory anymore, and say, well, maybe we'll get to it later. That's a big portion of our kids, right? And when we think about children in our schools in Texas, 63% of all the children in the schools in Texas are from low-income families. And in Texas, that means hardworking families. These are families with a number of jobs going on. And if they don't have time to get the vaccination, it's not mandatory, we're going to have a large group of kids that are unvaccinated that will be susceptible. Now, we think maybe the measles outbreak may put some pressure on our state legislature, so we won't get some of that anti-vax legislation. But those groups are very, very strong, so we'll have to keep our eye on that. Christine?
All right, we're going to talk about a few socioeconomic status factors. So looking at public assistance, 32% of children here in San Antonio are living with some type of public assistance, which is a greater proportion than the rest of Texas needs. So a little bit more demand here in San Antonio. Poverty level, again, higher than the state average and national average. 20.4% of children live below the poverty line. And then reduced lunch is something that public schools offer. So 63% of students here in San Antonio and the state rely on free and reduced lunch, which is a lot higher than the national average. So here in Texas in general, there's a need for food.
Yeah, I think when it comes, one of the things that we can do is that the U.S. Department of Agriculture historically has really supported the free lunch, free breakfast, free after-school snack, supper, summer food programs. In Texas, we don't always take advantage of that. Our agriculture would like us to take advantage of that. Grocery stores would like us to take advantage of that. But one of the things that we like to do is to tell school districts, San Antonio's districts do very well when it comes to taking advantage of this, but this is not true across the state. There are charter school systems that really don't have high participation in school breakfast or school supper. And what we have to realize is that this is food for kids that are hungry, and it's free and it's cost beneficial for school systems to take advantage of these programs. So we're constantly trying to remind school districts, let's take advantage of these programs. Moreover, across the country, there's an EBT card that you could get for kids, still not available in Texas, even though it's free, that kids during the summer could have access to groceries. Their parents could have access to groceries. And it's about, so it's about a $250 million program. The state would have to put $50 million towards that to get it. And last year the state said, well, we really can't afford that $50 million to do the 250. It's a little bureaucratic. And this year we're trying to say, why don't we take advantage this year? Now, I don't know what's going to happen in DC, but I think that we need to continue to put pressure on the system to make sure that at the very least, hungry kids get fed. And so that's one of the things that we're working on.
So to put that in perspective, we talked about 63% eating free and reduced lunch. 1 in every 5 children here in Bexar County are food insecure. So of those that are food insecure, 34% of those don't qualify for any programs. So free and reduced, the summer meal programs, and so that kind of leaves them at a disadvantage. They're hungry, they don't qualify, what do we do? Like Dr. Bob was talking about earlier, this public schools really have stepped in to help close that gap. And so in 2023, we did our school food ranking. So it was data from 2021, 2022. We typically looked at that percentage of those who qualified for free and reduced lunch. Due to the pandemic, everyone qualified. So everyone was able to access free meals that year. So we looked at what school districts were doing this, what school districts were feeding their kids. And we found that on the top 10 list, San Antonio ISD was taking advantage of this program. So they were, I'm going to say 9 out of 10 for overall in the state of Texas. Everyone else on that list was in the RGV, which we know, again, they have higher numbers of lower economics children there. And then the top middle income schools. So kids that aren't, again, maybe they don't fill that need or they don't qualify for those programs. So Judson ISD, East, Central ISD were one of the top 5, 2 of the top 5 districts that fed their kids.
And historically, Harlingdale has also been one of the ones that has been one of the top overall districts in the state. So we see San Antonio certainly taking advantage of those, and which is very, very important. But frankly, right, every district should be really taking advantage of that.
All right, we're going to be moving on to education. So when we think about education, we think about this K through 12. We are going to focus on early education in this presentation. So pre-K enrollment across the state has decreased 20% since the pandemic. We have not seen those numbers rise up. So there's barriers or reasons that they aren't enrolling kids back into pre-K at this time. Not only that is that they're not entering kindergarten, not kindergarten ready. So only 50% of these kindergartners that entered kindergarten this year were considered kindergarten ready. That kind of again means 50% of the class is behind and they need to play catch up. That can definitely affect quality of education. So why is that important? So kids who actually attend pre-K, there's a lot of research that shows are less likely to drop out of high school, more likely to graduate high school, more likely to attend higher education. San Antonio is the second highest, has the second highest high school dropout rates in the state of Texas. So 2.7 for grades 9 through 12.
So when we look at pre-K and seeing this drop across our state, because before the pandemic, we saw slow increases in pre-K. And the state legislature even passed this early education allotment so that districts could do full day pre-K, which is very important. And so when we look at that, what we begin to understand is that the Children at Risk has been doing school rankings for 20 years, where we look at the best performing schools. And we look at this subset that we call gold ribbon schools. And these are schools with over 75% of the kids that are low income, but these schools that get an A or a B. And when we look at those schools, there are a number of factors, but the most important factor is, do kids do full day high quality pre-K, or at least half day of high quality pre-K? And we cannot find a high performing elementary school that serves low income kids where pre-K was not part of the equation, right? So in our state, when you have so many kids, 63% of our kids that are low income, if we want those kids to be successful, there has to be some high quality early education going on in there, and there absolutely has to be high quality pre-K. San Antonio saw the writing on that wall some time ago when they said, we're gonna do pre-K for SA. But when you look at the numbers that's impacted, right, those kids do very, very well. But it needs to be sort of more universal, right? There needs to be, all those kids need to be in some sort of pre-K. Moreover, best practice as we look across the country is that the kids that are in high quality pre-K together, that they go into K together, 1, 2, and 3, or at least all the kids that are in that classroom have had that opportunity to be in pre-K. So it's another best practice that we look at that we need to see in operation across the state of Texas. When we see districts that are doing well, across our state, they have superintendents that have said, we're gonna fully focus on pre-K. We're gonna make pre-K a high priority and then sort of get those kids to move through our system, and we'll see those results. And districts that have done that have had some pretty nice results.
Awesome. So we're going to talk about early education. So childcare. So here at Children at Risk, we put out childcare deserts every year, looking at the number of childcare seats for every working parent who has children. So here in Bexar County, when we're talking about subsidized childcare, that's for low-income families. So families probably need 2 incomes. I mean, the reality is we all need 2 incomes to survive now in this economy. But so we're really dependent on quality. Well, this is just childcare, be able to afford childcare. So we're seeing not so great results across the state. So here in Bexar County, 18.1, so 18 seats for every 100 children of working parents. We saw an uptick in 2020. We had some ARPA dollars that helped to keep those childcare centers open. Those were no longer funded as of 2022, and you can see that big drop. So parents who are really relying on this affordable childcare aren't able to access this.
Yeah, and when we look at early education, it's interesting to me in Texas because as a state, it's not a red or a blue issue. It's a childhood issue. And so the governor, as an example, supports early education. And so there's been a lot of support for us doing the right thing in early education. Not a lot of money forthcoming, but there's been a lot of support. And so one of the things that we'll see in the near future is that we'll see local communities. And Austin just did I think it was Proposition A, I think it was in Austin, where they said we're going to set aside tax money, property tax money, to go towards early education and after-school programs. And I think we're going to see a lot more of that going on around the state, where people say, all right, what can we do around early education to support our families? Again, working families, they need a place to put the kids so they can be part of the workforce. So it's increasingly something that we're seeing happening. And so it wouldn't be surprised in the next 5 years or so that there'll be an effort in San Antonio to say, hey, what can we do to really support early education? And I think there's going to be an increasing amount of pressure on the state because it's not a red or blue issue to figure out how do we fund early education. During the first Trump administration, more money came to Texas for early education. I don't know if that will happen again. But I think that was good, right? That we got more money for early education. So we'll continue to work on this area. But this has a big impact. Last year, when Mary and we did this, we asked all the 5 experts at the end if you could invest money in one place that would have a change in outcomes for kids. And all 5 of the experts said early education. So it's, for those that know the research, early education becomes very, very important. So when Christine does the childcare desert maps, these are communities that are having this very tough time getting to childcare. It shouldn't be tough to find quality childcare in our state, but it is. It's only 18% of parents are finding access to quality childcare when they're in the low-income households.
So this is the last slide. So when we talk about early education, high quality, so everyone wants the best for our children, right? And so when we see access to high quality, so TRS is a state evaluation for the quality of childcare, only 6.8 here in San Antonio. So if, again, thinking about your own children and other children who are going into kindergarten, maybe not being able to access what they need to be kindergarten ready.
Let me ask you, since this is our last slide, Christine, what piece of data, when you did all this work, sort of was most alarming for you?
I think that, so the measles, I have a child who just got vaccinated. She wasn't of age. So when we think about the number of children who can't get vaccinated, maybe they're not one. What does that mean for our community? So we knew that someone that was positive was walking around the Riverwalk. You don't really, locals don't go there. But I was scared to take my child out, right? To go to the park to get exposed to it. And so
You got a bigger laugh there than I ever did. Just a little envious there, Christine.
So I think I think everyone's watching it. We're sitting and seeing what happens. So what does this mean for our community? And you see within the districts, yeah, we have a 6% exemption rate, but some districts have 40%, 30%. And so I think keeping an eye on those areas.
And I think a lot of people, I think the general public, and probably most people here do, don't realize how infectious measles is, right? How devastating it can be. Bring the mic over to Mary. Mary, I want to ask you, when you look at the data, what's the thing that most alarms you?
Everything.
Oh, that's an easy answer.
Yeah, I know. But right now it's the direction we're going in. And so when you're talking about early child education, just in San Antonio, we have over 7,000 early Head Start slots. And the current budget proposal from the House is eliminating Head Start, early Head Start. That's federal grant money that will take away over 7,000 slots for high quality early child education and development. And that's not just affecting the children, ensure they're ready for kindergarten and life success, but also affects the families, because Head Start, early Head Start is all about families. When it was created 60 years ago by LBJ, a Texan, it was to help pull families out of poverty and give these families an opportunity for life success that did not exist previously. We don't want to go backwards on that. And in that, with using early child education as an example, everything else ties in. So having the vaccinations and understanding that for families at a very young age, so they're not going into first grade because kindergarten is not required in Texas, which is crazy too, but having them understand that need to be ready, and all of those children's supports that families need to understand to help their children, which then helps the entire family unit. Absolutely, everything is integrated.
Thank you very much, Mary. All right, and you have some final remarks, Christine?
Yeah, just again to tie in what Mary said. So addressing these social determinants of health is really essential for creating an equitable and healthier society here in San Antonio. By tackling these and understanding these root causes of health disparities, we can improve the health outcomes for everyone, for all individuals, regardless of their background, of economic circumstances. So really looking across your own sector, where do you kind of touch these children, and where do you work, and what can you incorporate into your own services? Thank you.
Very good. Give Christine a big hand.
Sorry, one more thing about this integration piece, the mental health piece too, and the physical health piece. And again, Angie White's in the room, CEO of CASA. And again, the research is showing that when families don't have access to high quality education and development, but they need to work, they have to work, then they're going to find places to put their children. And they try to do it in trusted family or friend environments, but research shows that sometimes too often, where they put these children end up being in unsafe places. and they end up being abused physically, mentally, sexually, etc. So we're neglected. So that is another integration of the importance of access to high quality education for young children, because it helps on so many levels, not just the education, but the physical health, the long-term outcomes, etc., etc.
Thank you very much, Mary. Let's have our panelists come on up. You guys come on and grab these seats up here. We have you up on these little high chairs, so that should be good. And we're going to explain how you guys can ask questions. And this is Nadia Salibi, who's on our team. Nadia?
Yes, so real quick, everyone, you should see a few of these on your table, little QR10s. Code is also up here on the screen, but we'll probably switch it over to the panelists, yeah. So what I wanted to say is during the conversation, any questions that come up, we want to make sure that you leave some space to try to get, maybe not to all of them, but some of them. So just follow the directions. You can scan that code, and then there's a few digits that you need to enter in, and then we'll be receiving those questions. All right?
Very good. I loved Christine sort of talking about the idea that the Riverwalk was not visited by you guys. So I'm sort of amazed by that. So the locals, Norm, you don't go down to the Riverwalk? Yeah.
6th Street either.
No, you're not in Austin, you go on 6th Street, yeah, that's right. And when I lived in New York, I never went to the Thanksgiving Day Parade, right? People are or Times Square for years. We had some Swedish relatives, my wife has Swedish relatives, and we said, oh, we're gonna bring them to San Antonio from Houston. And they're like, oh, that sounds fun. They had no idea what, and we brought them on the Riverwalk, and they said, oh, this is really nice. And I said, do you guys wanna see the Alamo? And they're like, well, what is the Alamo? It's like, because we sort of think, like everyone knows what the Alamo is. In Sweden, they have no idea. They're lost, I think, maybe. I don't know. So let's introduce our esteemed group of panelists. Norm Christopher is with us. Dr. Christopher is the medical director at Christus Children's Hospital. Thanks for being here, Norm, very much. Steve Kelber is with us. Yep, go ahead. Steve is an old-time buddy of mine, and Steve is out at the School of Public Health. And is it the Dell School of Public Health, or you're the Dell Center of the School of Public Health?
The Dell Center inside the School of
Public Health in Austin, so he's in Austin. Steve does a lot of great stuff, which we'll hear more about. Dr. Zoe Hafiz is with us. He's out at UT Health in Houston. And one of the great things about Zoe is that he is focused, as a medical doctor, focused on the built environment. And just some really interesting stuff. So Zoe, thank you so much for being here. Give him a big hand. He's also part of the Baker Institute at Rice University, so I worked with Zoe there. Dalinda Alcantar, Gonzalez Alcantar, she is the CEO of the Boys and Girls Club down in McAllen, Texas. And yeah. She's also a trustee at South Texas College, but I've known Dalinda for a while. She's fantastic. Thanks so much for coming up from the Valley.
Absolutely.
So, yeah.
We do go to the Riverwalk.
You're not a local. You're not a local. And then last but certainly not least, Dr. Leo Lopez. He is the chair of the Chief Community and Population Health Officer at University Medicine. Give him a big hand, Leo. So I wonder if we might start. Leo, I'll start with you, and then I'm going to go to Norm over here. When we look at, because you guys are doctors in San Antonio, and when you think about this whole idea around health and where we're going health-wise in San Antonio, what do you see as sort of the major concerns with things that are going on for our children in San Antonio?
Sure. Can folks hear me okay?
Yeah.
Excellent. To kind of level set and ground us, I know often we get caught up in data, which is essential to help kind of drive change, help us understand and develop kind of our problematic statement and drive interventions. But I do want to take some time to kind of ground us to recognize the humanity behind those data, behind the numbers, and to realize we're going to talk about the non-medical drivers of social determinants of health, which impact the work that we do every day, every patient, every time. But I want to spend some time to define something. Poverty, and the way that informs our work, when we think about it, is more than just a line, right? It's more than just an income line. It's a state that is debilitating, that is stress-inducing, that is causing embarrassment and humility, and it is to live with psychological pain and emotional pain and physical pain. And it's this sense that with each day, with each moment, things are getting worse. It's the sense that your community, your government, your neighbors are against you. And that is, it's important for us to kind of start, I think, and center ourselves in conceptualizing poverty in that way. In the work that we do, I supervise a network of clinics in the historically redlined areas of San Antonio. It's important for us to recognize that history and to confront it, not to ignore it, because the inequities that were implemented a century ago persist today. And we know that our neighbors, what we practice on the west side, on the east side, and the south side of San Antonio, are working every day to try to care for their children. And that is the mission that we set out to do in our work. To kind of give you an idea of what our kind of shining star is, because it helps us understand and recognize the space that we share today, are the disparities in life expectancy. We know that if children here in this community that grow up, they might expect to live 20 years younger than those that live north of Highway 90. So we work every day to try and address that, what we feel is an urgent crisis. So as we're developing policies and programs and interventions, we've got an eye on how can we not just decrease and eliminate those disparities in life expectancy, but how do we optimize life expectancy and quality of life? It's not enough just to live longer, but to live with vitality and that sort of thing. So that kind of gives an overview of the work that we do and some of the challenges that we work to address every day.
Dr. Lopez, could you drill down a little bit around social determinants of health, though? And like, when you see the environment in San Antonio and those social determinants, I mean, you pointed out a few of them there, but where are your big worries?
It's an excellent point. And so what I'll say is, I'll give an example of some of the work that we do every day. Those of you might recall back in 2023, the U.S. Surgeon General declared a crisis of loneliness and social isolation. So we wanted to anticipate our patients' needs, and we wanted to work to understand how that impacted the children we care for in our school-based health clinics with San Antonio ISD and with Harlandale ISD. So we implemented an integrated social needs screening process. So we began to screen the children that we care for their social needs, specifically around social isolation. And we found that nearly 1 in 3 of the children that we care for are suffering from social isolation. And we should all recognize that that's unacceptable, and that we all have a role to play to address that, because we know when children in particular are socially isolated, it's going to increase their risk of poor mental health outcomes, increased risky behavior, increased risky sexual activity, and increased violent behavior as well. And so we identified that, but we also had an intervention that we developed. We worked to connect them through a Find Help portal for wraparound social services, connect them with a caring adult, with mentorship and other services around the community. We began to pilot and demonstrate that. And then we took that a step further. We connected with family service, and we shared with them the data that we found, and we said, how can we work together to address these needs? And so we were very happy and pleased that family service we've now integrated their counselors right on site at our school-based health clinic, so we can work together as a community to address this crisis. And we're proud to say that we've just been invited to Washington, D.C. this summer to share with the rest of the country the work that we're doing right here in Bexar County to address social isolation.
Dr. Christopher, can you sort of, from your perspective, where would you say how are we doing here in San Antonio around social determinants of health?
Yeah, let me just first say what an intimidating task this is. First with the panelists, who are all experts in their areas, and with all of y'all who are, really boots on the ground, and it seems a little bit artificial to even try to talk with you about this, but I'm going to bring a very unique perspective. I'm an emergency physician by practice. I spent my entire life in my professional career in what I believe is the interface between the community and the health system. And over a period of years, I've taken on additional leadership opportunities and trying to understand how to drive change in health systems. Every single person I work with and work for in my health system is committed to our mission. We all understand that. Our facility is downtown. That's not an accident. It's downtown because that's where the most needy children and families really in our entire community, I think, are. Having said that, it's very, very difficult in the context of a health system to break out of what I guess I would call a medical model, an illness model. We spend a great deal of time talking with families, interviewing children, doing physical exams, developing plans, and prescribing treatment, and then working hard to make sure that those kids have good follow-up and that they have a home somewhere in primary care. But then in a health system sort of model, in an illness model, you know, we clap our hands, we move on to the next problem. All of us understand these issues. We don't always recognize the social determinants and the impact that they have on these kids when they're right in front of us and their families. The advice I give, most importantly, is to ask, you know, talk to these families and ask them, are there things that are inhibiting you from achieving your health goals in your family? Are there barriers to getting efficient and timely, high-quality healthcare for your kids? Are there things that you're trying to overcome but you just can't, and because of that, you're using the emergency room for minor things just because you're not focusing. We're not helping you to focus on prevention and on wellness and even more so those kids. We care for so many young people in this community who have chronic complex conditions, and we see them and we care for them, but it's typically at a time of an exacerbation, and for them to receive high quality care in a preventive sort of health environment is very complicated in the current health system based on what we're incentivized to provide, what we're paid to do, the support that we have, and just the most important thing I'm going to say. Now, I've been in San Antonio for 4 years, and I have never been in a community that's warmer and more welcoming, and that has more depth and expertise in the community. And I would encourage all of you in your work to reach out to people in the hospitals, work with them, offer partnership, offer collaboration, because that's how we're going to get better.
Yeah, very good. Thank you so much, Dr. Let's go to Delinda Alcantar. So Delinda is the CEO of Boys and Girls Club down in the Valley, and I remember taking a group our team down to the Valley. We were meeting with different leaders, and everyone was blown away by Delinda and all the work that she's doing at the Boys and Girls Club, because it went beyond what most people think about Boys and Girls Club. Delinda, for you guys, obviously you're dealing with a lot of poverty in McAllen and in the Valley. What is the big thing for you that that is sort of a prime objective, if you will, around with dealing with poverty and sort of getting these kids to break that cycle?
So in reviewing the data from San Antonio, I want you to kind of picture, if you haven't been to the Valley, which you should, and you can...
do you have a nice river walk down there?
We do not. We have a river, clearly you all know that. We have a river. That's my home, and a ridiculous fence. It doesn't work. So, okay, it really doesn't. So, we... I forgot the question because it's just so annoying. Okay, I have to say this. Okay, I don't know if you've seen the meme where there's like goats and there's a fence, and all they have to do is go around it. Okay, well there's like pockets, like huge pockets. Stop recording. Where all you literally have to do is go around. Okay, I know it's not political, but it's like that. When I see that meme, I'm like, that's us too, so whatever. Okay, so when I reviewed the data from San Antonio, I want you to understand we're probably between 15 to even 25 percentage points higher. So I noticed like 26.9% in terms of poverty and children living in poverty. So we're probably hovering between 38 and 39% living in poverty, okay? And I will tell you also this, when you look up McAllen, if you Google McAllen, it is a beautiful place and we're growing. It's actually one of the fastest growing areas in the entire country. Right, we have a medical school over there. I'm privileged to be able to serve as an elected official. I'm a trustee at the college, in which that college alone, in 1992, when it was established, We went from double-digit unemployment, and now we're hovering probably 1 or 2 percentage points higher than the state average, which is amazing. Because again, when you have access to education in your space, right, in your environment, in your neighborhood, things change drastically. But we still are really suffering from poverty. And we are suffering, and our children are suffering from poverty and the outcomes associated with that. So I've been revamping the conversations around ACEs and adverse childhood experiences and saying things that we do, CASA, Boys and Girls Club, all of the nonprofits that are out here, we're there trying to play very strong defense in real time against all of these. When we talk about social determinants of health, when we talk about ACEs, our children are living in trauma when they live a life of poverty. And nobody wants to say that, but they are. They're living through trauma if they're having to struggle, because we know all of the outcomes that are associated with that. So one of the things that I feel, and I was in education for 13 years, and so, and now as a policymaker, I really wanted to make sure not to squander the influence that our Boys and Girls Club had and the privilege and honor we get to serve our families. So like Dr. Bob mentioned, we definitely go above and beyond. So one of the things that this is important for everybody in this room to remember, 80% of a kid's time is actually spent outside of the classroom. 80%. So what is the community doing? What are policymakers doing? What are elected officials doing to respond to what they're doing in that 80%? In our particular case at our Boys and Girls Club, we are evidence-based, we're outcome-based. So we make sure that the kids that go into our space, they receive academic intervention. We make sure, of course, that they're eating every single day. Everyone who goes to our Boys and Girls Club in partnership with our school district, they eat every single day. But then, because we're not a government entity, because we're not public education, we're a trusted logo and brand in the middle of neighborhoods that moms and dads know that we care about their kids. They allow us to serve them in new and different ways where they're not going into schools to get probably the same services. Like they could get college readiness programs and parent engagement programs at their school. But many children that are living in poverty, their parents had a horrible experience in public education, or they're intimidated by a government institution. But at nonprofits, us in the front lines, they know we love their kids. They know that we're there. And so we do things like workforce development opportunities. If you want to take away just real quick, in combating poverty, a model that we've done at our Boys and Girls Club, we partnered with our local college through a foundation grant, and kids that were at risk of dropping out, but I knew that they had so much potential that we partnered them, and in the summer they received an EKG certification course. We paid for it, we made sure they had snacks, we made sure they got there every day with the bus, we made sure that they were fed, we made sure that we paid for their scrubs. 14 out of those 14 kids at risk of dropping out passed their certification exam.
That's a very nice example. Snacks, of course, always very
Always
important.
snacks. That's how we got them. We got them with snacks and a dinner midway and then a dinner after. Yes.
Wow, fantastic. Thank you, Belinda, very much. I want to go to Dr. Hafiz. Zoe, first off, I'm looking at your picture that we have up here, but I love the beard. So I think Steve and I both agree the green beard really is everything. So thank you very much. So Zoe, the built environment. When we look across the state of Texas, we're probably not where we need to be around the built environment, and certainly children, right? I think if you want to drive someplace fast, usually we do pretty well. Not always in Austin, it's a mess, right? But I think that, but for children, it's sort of a harder deal. Talk about what that means for kids when, whether it's in San Antonio or somewhere else, the built environment isn't built for our children.
Yeah, that's a very good point. First of all, thank you for having me. Really is a pretty big honor to be at this in this panel, like listening to everyone else speak. When it comes to the built environment, I will say Dr. Bob mentioned it perfectly. Texas roads are good at going fast on, which is pretty cool if you like to go fast enough to get to places quick. It's not as cool if you're a child walking or biking, right? One of the, I would say, big opportunities for us is to fix that issue. So I practice as a hospital pediatrician at Children's Memorial Hermann Hospital, which is associated with UT Health at Houston. And we are, similar to a lot of y'all, we're tracking these social determinants of health needs. One of the things that I'm super excited about is we're mapping it. So we got geospatial data, and now we're trying to map out. We got a lot of observations, because it turns out there's a lot of kids in Houston, shockingly. So one of the things that we're realizing is, now that we're starting to map it out, this is a little hot off the press, but we're realizing that as you get closer to highways, more people are reporting transportation insecurity. And so what does that mean? That means that the roads that we're building, I'm not saying this is true, I think this is true. The roads that we're building are paradoxically obstructing children from mobility freedom. No one's shocked, right? If y'all live in Texas, y'all are not shocked. And we see this with our family. I think I'm answering the question. We see this with our families where, I'll just tell you the story.
Go ahead, yeah, please.
But I just have to tell you the story. So I still do a lot of time as a pediatric hospitalist, which is, just for fun, I'll tell you, I'm Dr. Christopher's worst enemy, because Dr. Christopher will want to admit a child to our service, and I go down and say, this child, absolutely not. And then if you ever watch Scrubs, it really is true. One of the things we notice when I occasionally do admit a patient, one of the things that I was just talking to a family yesterday where a child got really, really sick because they didn't have access to medication. They didn't get their medications. Super simple problem, cheap medication, easy to get, wasn't gotten, patient almost died, and now they're on our service, right? And I was it was 2 o'clock in the morning, maybe I was a little more judgmental than I needed to be. And I said, what the heck? Like in a very polite way, maybe a little bit judgmental. And they said, well, and she was very polite, very sweet lady, grandmother. She said, well, there is a pharmacy half a mile away. I can't get to it. I don't have a car. I'm wheelchair bound. And I Google mapped the thing, and it's like crossing a highway. It wasn't a highway, it was like crossing a highway. And so that opportunity was lost, and how much money, forget about the morality of that, right? Forget about the fact that that child didn't need to be this sick and didn't need to be in my care. But think about the financial investment of just improving that crosswalk, improving the sidewalk profile on that particular road. How much lost potential for that child, and how much medical care costs by not providing a dignified crossing that costs our community. So I think I roundabout answered.
Yeah, let me do a little bit of a follow-up, Zoe. So when we think about walking to school, right? So many kids in Texas can't walk to school because the roads are bad, the sidewalks aren't there. What would that mean for kids if public policy-wise we just said, within half a mile, a quarter of a mile of the school, we need to make it super accessible for kids? What would that mean for children and their well-being?
So all suffering would go away immediately. In all seriousness though, I think one of the things, two things could happen. I think it would take one of the major barriers that parents have in terms of getting kids out and about by themselves, walking and biking to school. I'm looking at what I think is a variety of age groups. Did anyone here walk to school or bike to school unaccompanied and then come home from school and What if I told you less than 10% of parents do that now? And about 50% of parents allowed that in the late 1960s. Every generation it gets worse and worse. One of the biggest barriers that parents will tell you is, I just don't feel safe. I think my child's gonna get hit by a motor vehicle driver. And I think in some cases it's a very reasonable fear. Yeah. So if you do increase the infrastructure in a quarter mile around schools, which I think is a great idea, it doesn't take away all of their fears, but that primary fear would go away. And I do think you'd probably start to see more kids walking to biking in school. Now you have that power in numbers.
Very good, thank you very much. I'll let you applaud after Steve, and then no more applause till the end, okay? So, Dr. Kelder, so you're like our public health expert up here today. When you think about the dangers facing our children around social determinants of health and otherwise, what are some of the big worries for kids in San Antonio, the big worries for kids in Texas?
Well,
I think it's been said already here.
Yeah.
So early childhood is a great thing for kids. It's highly predictive of success. It's highly predictive of good health, highly predictive of educational opportunities, etc. The built environment's important too, because the kids need the physical activity to get back and forth from school. You know, as a public health professional, I know that the guidelines for kids are 60 minutes or more of physical activity per day. And so they could get roughly half of that if they just walk or bike home to and from school. If we did what you were talking about and build buffer zones or do like they've done in Sweden. I was there not too long ago, speaking of Swedish people, and they do have roads. You know, they have lanes for going both ways that are wider in any lane than we have here in Texas. So, of course, there's a measles outbreak. So as public health people, our antenna go way up, and it's not that I don't like the Riverwalk, but it's a little crowded, and that dude was walking around there with measles. So I thought I'll just stay away this time. So, you know, COVID was a big deal, and how we handled that, and what we did with schools, and how we closed businesses and when we reopened them and such. And so, what are the bigger problems? My guesses are that poverty is a big problem.
Yeah.
Lack of health insurance. We're one of the least insured states for children in terms of health insurance. So just the access to you guys without public services like many of the public or the nonprofits that help along those ways. That's a big deal. I think childhood adverse experiences. ACEs is a problem that's under-recognized, but I think what most people in my field now, and by the way, I write school health education programs. So I have a master's in health education, so I like to write programs and evaluate them. Then I have a PhD in epidemiology. That's part of my public health. I remember when I was getting my PhD in epi, my mother said, well, what, are you a skin doctor? No, it's public health, Mom. And that was a long time. People know what public health is now, but I will say my profession is under attack. We're under siege right now, and what's happening when they eliminate the Department of Education, there's a lot of good public health and mental health and health education with the terms of diet and physical activity. When we attack the FDA, there's laws and rules and regulations that need to be put into place that will help regulate things like e-cigarettes, which I've worked a whole bunch in. And now things are turning in the right direction. When we attack the NSF and start cutting grants, we lose the ability to, you know, in a systematic and large-scale way to evaluate programs that we think are helpful. I have a colleague who's waiting on a grant, really good grant, that's intended to help kids with Tier 1 mental health issues. It's called Finding Focus. By the way, if you just Google that, you can just go and get it for free. The intention for that program is it's funded by NSF, and he probably won't get his next grant. And if we don't get grants in my system, you're out the door before too long. Anyway, Finding Focus is one where kids learn how to control their mind to a certain extent and find focus so they can spend focus. It's shown to increase academic achievement, but you know what else it does? It reduces anxiety and depression. And so the mental health issues that are stemming out of COVID and maybe the result of many other factors, including childhood experiences and poverty and mom and dad laid off and all sorts of things. So I'm gonna have to go with mental health this time. And I really hope that now we can talk more about it and there might be funding for it. And by the way, I know that UT System in their population health department and Dr. Lakey, Chancellor, is putting on a program that delivers telemedicine and mental health to kids in schools. So if you don't know about this program, I know they're expanding it, and people down the hall from me working on that. But anyway, I'll stop there.
That's good. Thank you very much. Thank you, Steve. All right, Dr. Christopher, I'd like to ask you a question, maybe ask everyone sort of the similar question. When you think about broad changes that could be made in Texas and in San Antonio that would significantly improve the social determinants of health, the livelihood, the success of children, sort of what comes to mind for you as a broad change that could be made?
I'm going to make a comment first about my picture. I think that's the last time I wore a tie until now. As I walked out of the hospital this morning, one of the docs said, "Norm, you looking for a job? Why are you wearing a tie?" So I'm a little uncomfortable, but it's only good.
But we appreciate you wearing a tie. No one else wore a tie, and I even wore sneakers.
I was gonna take it off, but too many people had seen me already, so it would look bad. So.
Broad changes, Nora. What were the broad changes that you would?
Well, again, coming from the hospital practice perspective and more specifically from the emergency room perspective, and when I look back on my own goals for my the things that I want to try to drive in my work, it number 1, 2, and 3 is access to care. To have access to early periodic diagnostic and treatment options for kids in a preventive health environment, I think, is the number 1. That touches on mental health, which if I had to talk about all of the afflictions right now that are most important, it's mental health, for sure. We have a variety of services now in our emergency rooms to support that, but again, it's intermittent and it's acute. And it doesn't get to the heart of the thing, which requires an integrated model of mental health in primary care. And so to me, it's really creating access and moving away from an illness model to a preventive type of model.
When you think about access, when we look at uninsured children, right? The 3 cities with the largest numbers of uninsured children in the developed world are Houston, Dallas, and San Antonio, right? I mean, so when you think about that, and you think about how that's preventable in many ways, right? There's access for children, certainly, to some of that insurance. What could change to make, and this may end up being cut in Washington, right? But what could change if things stay the same way in Washington around insurance for children?
Well, the obvious answer is to expand Medicaid. That's been an issue here. I spent much of my professional career in Ohio, in Northeast Ohio, and it was an expansion state. It made a difference in terms of access and the number of kids who were uninsured or who were underinsured, more importantly, reduced significantly in that kind of an environment. I'm not sure that in the hospitals and health systems we were able to flip, even given that, to more of a preventive or more thoughtful, integrated model of care. But so the first thing, we have to protect Medicaid as it is now and continue to fight for expansion. The CHIP program, the Health Insurance for Children program is also just critically important. We're spending a lot of time on workforce development. You can't talk about access to care if you don't think about the workforce, and also innovative care delivery models. I was at a pediatrics Academy of Pediatrics seminar about a month ago, and they had shared results of so all of after medical school you do residencies, and then you decide if there's an area of specialty that you'd like to practice in, and you do another 3 or sometimes 5 years of fellowship training. When you look, the group of kids today who have entered fellowships, and they'll start in July, when they're done 3 years from now, there's going to be 22 new pediatric nephrologists, kidney doctors, 22 in the whole country. That's it. When you look at emergency physicians, a desirable job, a rewarding type of job, there's going to be 120 in 3 years. And that assumes that those 23 or those 120 don't have distractions along the way and fall out of that training track. So the workforce issues, as we look to the future, in pediatric healthcare in particular, absolutely require that we think in a more innovative way about how we deliver care. It's through partnerships, it's through other clinicians. It's time to do something different.
Yeah, and I would add to that I've talked to some of the deans of medical schools around our state. One of the key things is Latino applicants for medical school is really down.
Dr. Bob, can I,
Sure, I'll let you.
Well, my answer is so to piggyback off that. At the college, at South Texas College, we know that there is a nursing shortage all across the state of Texas. And Dr. Bob was, I think, about to continue with this comment, which is we also know that the large majority of children and college-age students are Latinos. And we also know that Latinos are coming disproportionately from homes that are living in poverty and families living in poverty, right? Okay, so that's all the things we know. Well, we finally did something about it because we said, well, the state needs more nurses. We are mostly working with Latinos and Black and brown communities, and we're noticing that they're going to school the first 2 years because they're getting Pell Grants. And then even the 3rd year, but then what we saw was a huge drop off. Obviously, because they can't afford to go into their clinicals and not work and get paid. They cannot afford to continue the fellowships. They cannot afford to go to school. So again, so much potential is with our children and with our college-age students, but they just can't afford to pause, right? So at South Texas College, we now are the first with the Department of Education to pay for nurses to go through their clinical practice. So now we are graduating more nurses. Oh my God, that's not that hard, you know? So yes, it's incredible. It really is amazing. And so my response to your question was gonna be this, which is, there's 2 things. One, because of the populations that we know we're working with in the state of Texas, we have to close those gaps. So one of the things we're doing this summer at our Boys and Girls Club with our Teen Workforce Development Program is this. I would call moms and say, we want your child to go through this welding program. We need a lot of welders. We want your child to go through this welding program. No, miss, porque necesitan trabajar. They need to work. Oh, I got you, girl, because we're gonna pay them $10 to go to school. So they're gonna make money in the now because they need to work to help provide and to buy basic things like food. So we're gonna pay them. And then they're gonna get their certification. So I think that I would love to see more paid opportunities. I'm trying to get off the ground in Hidalgo County where we have areas of adult learners that want to go back to school, but like I'm trying to tell everyone that adults, we all have adult lives with adult bills. And so they want to say like, more adults go back to school if you dropped out and didn't get your high school diploma and we want you to go get a 2-year degree. Yeah, but like, what are you gonna do to help me do that? Because I have to pay for rent. I have to pay for food. I have to pay for my daughter's $25 to go to main event, right? And so I have to pay, I have to pay for all these things. I want to do well. I want to do better. I want to get out of poverty, but I just can't because it's an amenity to think about the future for a lot of families. So that's one thing. And the second that I would say is it feels like it's pro-business and you're either pro-business and corporation or like good things for people. And I would love for people to understand, I'd love for businesses and corporations to understand that when you do things like expand Medicaid, let's take the morality out of it. We're all here, we're probably like fighting for the morality of it, right? I'm over that because that's not working. I don't know why people aren't better people. I don't know why decision makers don't want to do the kind and good thing like feed kids. So I started to say, well, you need human capital. You need someone in the workforce. Well, guess what? When they're starving and then they can't learn and then they drop out and then they perpetuate this like cycle, that's an issue for your workforce. So I want everyone to be like, if we could change anything in the state of Texas is like, nah, we're all trying to do the same thing. And it is pro-business to be good.
So Delinda, why aren't you the mayor of McAllen? I'm just wondering. All right. I want to get back to broad changes. Dr. Leo, can you give us an idea from your perspective? What are some of the broad changes you would like us to see in Texas and in San Antonio that would affect children?
Sure. I'll I think complement some of what's been said, and it's related to access and investment in our school-based health centers.
Yeah.
That's something that we've got.
And explain what the school, because this is such a great practice,
Sure.
right?
Absolutely. So we operate 5 school-based health centers in partnership with 4 school districts all across San Antonio. A school-based health center is a primary care clinic, and they vary across the country. And we're fairly unique here in San Antonio with University Health because our school-based health centers are actually primary care medical homes where we don't just address the needs of children and the school staff, but their families and the surrounding communities. Historically, many school-based health centers provide episodic, almost akin to an urgent care. A child might go in with cough, congestion, or runny nose and need like a sports physical. That might be the only time they interact with a school-based health center. But what we've done is we've created these medical homes to provide continuity of care. So when a child is coming in and they're socially isolated, suffering from depression, anxiety, or bullying, we can care for their entire healthcare needs. And we do have an integrated behavioral health model where we can address their behavioral health and needs as well. But when their father comes in, who hasn't seen a doctor in decades, whose diabetes is so uncontrolled that they can't feel their feet, we can care for them as well. When their mother needs their breast cancer screening, we can work to mobilize our mobile mammography unit, bring them out to our school-based health centers on the south side and get them the dignity of their cancer screening as well. So investing in school-based health centers has also been demonstrated in the literature beyond San Antonio to not just improve chronic disease outcomes like asthma and obesity, but also these non-clinical outcomes. School-based health centers have shown to reduce chronic absenteeism, promote academic achievement, and even boost graduation rates. One of the other initiatives or one of the other values that it brings too is, for working families in particular who have to find time to get off of work to get their child to the doctor's office when they're sick, that can be a life-changing process in and of itself. So we provide care right adjacent to the campus, so we're reducing those barriers to access and time and transportation that are really valuable to the parents of the children that we care for. So happy to take a deeper dive there, but we can all work together and invest in school-based health centers. We would improve the health of our entire communities and bring value to our neighbors out here as well.
And are they cost-effective, the school-based health centers? Because I know that's different across the country as well.
That's exactly right. So the key to it is sustainability. And so part of the changes that we've made here in Bexar County is historically for approximately a decade, they have been episodic and again, more of an urgent care, but in the transition to a medical home where folks can get their entire kind of care needs addressed from a primary care setting, that's brought sustainability to these operations for sure.
Very good, thank you so much. Let me change a couple of questions up. So Abe, I want to ask you, when you look at across the country now, not just to Texas, but when you look at some best practices that you think, well, that would really work in Texas. And, I travel the world over and I feel like I see some things that I could never tell the state legislature, this really works in Sweden. They'd be like, oh, But, we had a bill a number of years ago where it was something that was going on in Sweden, and we said, this is the Texas model. It quickly passed, by the way, because it was Texas. But when you look around the world, what are some models that you see around the built environment that you think, wow, this could really work in Texas?
Yeah, so I'll go to an exotic Austin, Texas, where actually Dr. Calder's wife, I didn't know.
The People's Republic of Austin.
The People's Republic, yeah. I didn't know it was his wife until about 15 minutes ago, but Dr. Deanna Holscher, who runs the Dell Center for Health, she runs it. Her and Deb Salvo and actually probably Dr. Kelder were involved in this really cool project where they were. I didn't know he knew so much about it, so I'm probably going to get it wrong, so please just cut me off if I get it wrong. But Safe Routes to School funding, and they took comparative non-intervened schools that they've been following. And just generally speaking, you don't need this is just my opinion, but I don't think you need some gigantic, incredible intervention that's a one-size-fits-all for every single neighborhood in every single city in Houston, in Texas. So for example, in one particular neighborhood in Houston, all they needed was one intersection to be unmessed up, like to make it so that children were running across the street trying not to get killed just to get to school every day. In another neighborhood in Houston, I know why, but it's just such a ridiculous problem. They have to cross train tracks. There was an impractical safe crossing that was just not really reasonable, and one child just a few months ago got run over by the train. Yeah, and so, but the truth is, if you go to that neighborhood, there really isn't a practical way to get to that school except to cross the train tracks. And if you get caught behind a train, anyone who's ever got caught behind a train, knows how long it takes. A lot of these kids, especially 15-year-old kids, who just want to get to school are going to try to beat the train. One kid didn't beat the train. So a lot of times it's one thing for one neighborhood. So it's hard to answer your question, but I would say the model really is that I'm shamelessly ripping off now that Dr. Keller's next to me, is what they're doing in Austin. It really, really works. And one of the things that we took Deb Salvo and Deanna Holster and some other people's research is we took their, what they were trying to do is they were trying to quantify every school neighborhood, every school that they could, and they would create the scoring system for it. And by the way, your wife knows about this, so I'm not ripping this off like unapologetically. We're taking that, I have email evidence that she's aware that I'm doing this. So we're taking their work and turning it into a one-pager. Effectively, a very recreatable, fast pediatric walk score for every single school that you could probably do a school in a few hours. You could score an entire school in a few hours. And every single metric that's being quantified is repairable, right? So is it a school architecture problem? Is it the city street? Is it the intersection right by the school? Is it a mid-block crossing? Is it an unshaded pathway? Is it that you're walking by a bunch of empty lots with unchained dogs, which is a big problem, I'm sure, in San Antonio too, and it's a huge problem. And so it's not fun to go to school being chased by a pit bull every day, so it was what I'm told. So so just finding the thing for the neighborhood, I think is the key.
And I love how you use data so much, and I think it's interesting. People could, I don't want them to do it right now, but you could look up even your own house, what the walk score is for that neighborhood, and to see how, but one of the things that you do a lot of is this mapping of like, where is it dangerous for children? Talk very briefly about that, so, because I think it's very interesting.
With the Baker Institute for Public Policy at Rice, we mapped out where kids walking and biking are getting hit for Houston region, but this is very easy to recreate for any city in Texas, where kids walking and biking are getting hit by motor vehicle drivers. And we essentially took, we used statistical analysis and we figured out where these statistically significant hotspots were. And it was very non-random and very not what you expected until you go to those neighborhoods. One is in Southwest Houston, Alief, a very culturally diverse neighborhood. And I went to the intersection, it was one of the really, really big hotspots. Like 4 kids were killed. Sorry for speaking so bluntly, but were killed in that one intersection. And I was like, why did this happen? I was crossing the street and a guy was driving around the right turn, it had to be 40 miles an hour. I had the walk sign, came this far from my legs and just started honking at me. And I was like, oh, okay, I know how. All right, roger that, I figured that one out. So that's work that we did, and it kind of showed that you wouldn't know until you map it, and then you can confirm it with your own eyes.
Yeah. Thank you very much, Dr. Feets. Steve, I wonder, so much of your work has been sort of around, for lack of a better term, some of the dangers that kids face, whether that be vaping or obesity. And so when you look at what's happening in Texas right now, I mean, you mentioned mental health, you mentioned measles, but I wonder, sort of big picture type things, what should our state legislature, if they were thoughtful, what would they be focusing on public health wise?
There's so many things. Well, obesity is still a problem. It's been a growing problem forever, and it's leveled off a little bit, but it's still way too high. What happens when you're obese and when you're eating ultra-processed foods all the time? We're going to end up with these guys with fatty liver disease, diabetes, early onset, etc. And those things are just so...
You don't mean these guys have fatty liver disease, you mean these guys that take care of them.
The ER docs and the physicians in the room and sitting next to me, they sooner or later they're going to see these people. Yeah. So from a public health perspective, which by the way I think it's fair to say, what we try to do is maximize health benefits with the least amount of harm. And so how do we do that? Well, maybe we can get to children and families at a young age and teach them what healthy foods are. and what less healthy foods are. In fact, Lois Colcourse has a bill that's running around now about ultra-processed foods and physical activity. And I read that as possibly maybe bringing back to schools some funding to help do these things. You know, one of the reasons, there's a lot of great food in schools, and it's good that we have free and reduced lunch. And although it's kind of hidden in the sense that when you get a pizza from a school, it's actually not the same pizza as you get from Domino's. It's a pizza that has the nutrients that are necessary. Still ultra-processed though. So we're working on definitions of ultra-processed. I think we're very close to having a standardized definition of it. So then we can say, well, how much ultra-processed food is there? When I started in Texas, most schools had a kitchen where they made their own food. They would bring it in from the local farms or maybe from HEB and so on. Now, it all comes prepackaged and you heat it up. And that pre-packaging means that every 5 years or so, there's a contract being made with the food producer in a school district, and they have to cut costs. Everyone has to cut costs. So it's ultra-processed foods. So I'm hoping that those cohorts in this bill will have something to say about that. And also with physical activity, you know, it was in the late 90s when George Bush was governor and standardized testing started in Texas first, and then when he became president, he brought it to the nation. People really don't like that so much now, so it's starting to recede the standardized test. But what that meant at the time in Texas was that we need more time to kill and drill, is what the teachers say, towards the test. And when that happens, what can we get rid of? Let's get rid of music or eliminate the number of hours. Let's get rid of art, or let's get rid of PE, or let's get rid of home ec. And health too. So all the things that make school fun. Well, algebra's not that fun. I took accounting in high school too. Anyway, so these are problems that occurred and led us down that path. So what did Texas do? A group of us, including health department and medical associations, said, well, no, we need PE. So now there's in state statute, there's a certain number of minutes that kids are supposed to get with quality PE. The same with middle school. High school, this all sorts of fall apart because there's too many topics and they just can't squeeze much help in at all. But in elementary school, middle school, you can. So I think working with state legislators, and if you look at the state education code, they've got coordinated school health programs are defined first by physical activity, then by healthy eating, and then each session they add a new thing. And so it could be smoking that they add to it. Smoking prevention is required by schools. Or it could be mental health type of training for kids. Along the way, about 8 years ago, someone, I don't know who, added dental and oral health. And so what that means as a person who writes programs for schools related to health is each time that happens, I like to, and I do, and there's actually funding for it. I write a new program for whatever's on the table. And so a while back it was oral health, so we created a program called Catch Healthy Smiles. We're evaluating it in Houston, but it's a very popular program. It's in many, many different schools. So I'm losing track of what your question was.
No, that's good, that's good. I think I remember a number of years ago when we had, and I think we worked together on this, Steve, the idea that every school district needed a policy on recess, right? So a lot of recess was being eliminated. So we said, there just needs to be a policy. We're not telling you have to have recess. You just have to have a policy so we know that you've thought about it. And I remember trying to convince legislators when they're saying, well, why is this important? We had to say, well, you know how if you don't walk your dog, they get a little mischievous? It's the same with kids if they don't get out. And the fact that we had to compare to pets for people to understand, it was sort of an odd little deal, right?
That's exactly right. Yeah. So when that happened, we, of course, advocated as public health with you.
Yeah.
And then now schools, they have recess, and what do you do at recess? Well, now that we're in this digital age, kids are outside looking at their phones. So how do we make playgrounds friendly, and how do we encourage kids to be physically active? So we got some money and did some research and built playground markings that are very inviting so that games could be played again on school. So that's what we do in public health. And the physicians and clinicians are taking care of problems that are right now. Whereas in public health, at least from what I do, I'm looking at ways to try and prevent those things from happening in the first place.
Yeah. Let's take a question from, do we have any good questions there, Mary, Nadia? They're all good questions. What's the best
We have
one?
lots of good questions and probably more than you'll be able to answer at
let's
this
do
point,
one or
but,
two.
we were gonna give you more than that, but, one easy one that I think is relevant, Dr. Mies touched on it, is can you address environmental factors when it comes to health in children, such as water, climate change, et cetera? For anyone, but, you've been talking about, but all of you understand that impact, so whoever would like to chime in, maybe more than one of you could answer.
I don't mind.
Steve, go ahead.
I teach a course in child and adolescent health, and so I've added climate change lessons. In fact, I taught a whole course in climate change, and it focused really on children. And when you think about adverse childhood experiences, how would you like your home to be destroyed? You're standing out in front of it, and someone died in a hurricane, or the floods in Houston, or just the variety of things. Add on top of that heat exposure, overheat with women that are pregnant, overheat with the kids. So there are many, many health concerns regarding climate change in kids, and maybe one of them has to do with increased anxiety and depression too. It's affecting children's mental health, just hearing so much about what the world might be 25, 30, 50, 100 years from now. And so I think we need to at least bring that into the mental health loop, like how to help kids address these concerns that they're having, because some will obsess about it, maybe not many, but some will. Climate change is very real, and it's going to hit the kids pretty hard.
I think what's interesting about this is that climate change produces these off-the-wall weather events in many cities, right? And for children, sort of a key thing is sort of normalcy, routine. And whenever you have a hurricane or whatever you have that sort of disrupts your school, disrupts your regular life, it's traumatic for you, right, as a child, that you're not doing the regular thing. And so that's a huge deal. You want
I'm going to just quickly, I'm going to tell a very quick story.
Okay,
Hospitals every 3 years or so are required to conduct, usually with their university partners and community partners, what we call a community health needs assessment. No matter where you are in the country, you end up with the same top 2 or 3 things in children: obesity, asthma, mental health, maybe 1 or 2 others get popped in there. The typical way that hospitals respond to that is by picking one of those, defining what healthy looks like, defining what better health looks like, getting some metrics, putting a few little programs in place, and then measuring it again a couple of years later and seeing what happens. It's my dream, and I've not been able to make this happen yet, but instead of picking an entity, pick a neighborhood, pick a census tract, pick a zip code, pick a block, and then just say, working together with legislators, with community leaders and stakeholders, improve health in the entire neighborhood that you're going to adopt, you're going to partner with. And that includes things like the built environment, making sure that there's lighting so that it's safe in the evening, making sure that it's walkable, making sure that you've got fresh food availability to them, making sure that the schools are part of that, so that you can put health clinics in the school and do it in a very, very meaningful and integrated way. So that's something I'm going to just continue to push for. It's very difficult to do as a hospital, but with the right kind of support and partnership, I think we ought to be able to do that sometime.
Excellent, very good. All right, what's another good question, Mary?
Next
Excuse me,
question
can I
is.
toss in one more thing
please go ahead.
related to what you were saying?
As long as it's super, super brief.
Yeah, it is. One of my former students created something called the Climate Vulnerability Index.
Oh.
And Grace Kong is her name.
Yeah.
And so that's a place where you can do what you were saying. Pick a neighborhood. Well, you can pick a neighborhood and look at its vulnerability and then get suggestions on community actions that can be taken. So it started in Texas. She lives in Houston. And now they've expanded it across the country. And she's getting inquiries from other countries to be able to do the same. So information is power.
Yeah, we work very closely with Grace. She's extraordinary, right? Some of the work that she's done. All right, Mary?
All right, next question really ties to a key reason why all of you are in the room today. How do we work to build coalitions among all the organizations in this room? And I'll add that and beyond across sectors.
I'll take that because I wanted to make sure to get everyone to write down, please look up Hidalgo County Prosperity Task Force. So again, it's the Hidalgo County Prosperity Task Force. Please look it up, because that is exactly what we've done. Our judge from Hidalgo County, Judge Cortez, you can look up his name and it's going to give you a framework. So Judge Richard Cortez, remember what you're looking up is a community, my home, that is the unhealthiest region in the country, the poorest region in the country. But Dr. Bob can tell you that we are outperforming, wildly outperforming in education, in just high school diploma, and as well as post-secondary ed certifications. And in my opinion, it's also cultural, because somos familia. So if you go down there with the two things that I told you, high poverty rates, unhealthy, all of these other kind of, determinants, you also won't see very high levels, yes, of the definition of federal poverty, but we take care of each other, because that's what we're known for in the Latino community, and you see it over there. Taking that concept and creating the Hidalgo County Prosperity Task Force, where we have created anywhere from mentorship to public health to, of course, education, and there's probably about 100 organizations that have come together on a monthly basis. And we are combating poverty because we have this advantageous goal to eradicate it from our region.
Linda, let me drill down there, or maybe I should say Mayor Alcindar. But I wonder, Linda, if you might talk about, because to be collaborative, you have to be intentional. So how are you intentional as the CEO of the Boys and Girls Club in working to create collaboratives or working to collaborate with others?
For sure. A lot of it relationship building. A lot of relationship building, a lot of coming to the table, knowing that you don't have all of the answers. You're being very vulnerable. I like to ask people for their advice, and then that begins to really build up, where we then have a collaborative, right? We place the objective in the center all the time. In my particular case, the Boys and Girls Club, we get funding and dollars from the city, state, federal foundations, unrestricted fundraisers, and sometimes we don't agree. But what I always do with intention is I start it by saying, remember, we're here for the kids. And this is what we're trying to solve. And then we start the conversation, and honestly, it is so helpful with intentionality to go into these difficult conversations and lots of ways to maybe solve the problem. But we always put that at the center, and I think that's very helpful when we meet together, especially when you have a lot of leaders in the room, because when we go out into our separate spaces, we tend to be the experts, or we assume that we are. And so that's difficult, but I think with us, in our region, we're so tired of everyone else talking for us, and we know what we have. And so we are coming together to, again, combat that poverty, but doing it together, knowing that we can't do it alone, and that's what we're known for. We know that we cannot do it alone, so we're coming together.
Yeah. Dr. Lopez, I wonder if you might, because you and I talked about how collaboration is going to be the key to success for children. Talk a little bit about the things that you guys, or how do you view the collaboration that you're doing?
Sure. I think to kind of also complement what's been said is kind of embracing this like Socratic adage that the true mark of the educated person is the one who knows that they know nothing, right? And starting with intellectual humility, that we don't have all the answers. And then I think another important piece is meaningful engagement of our community. For at least 150 years of medicine, it's been this kind of top-down approach where the physician states by declaring this is the way things should be done, and it's got to be my way. But we've got to be okay with relinquishing power and really engaging our community, particularly those that have been marginalized and excluded from power, privilege, and decision making, and putting the community at the center of all things. There are different ways to operationalize that. I was the former co-chair for the New York City Community Advisory Board. We had over 50 community-based organizations, some of the most incredible advocates that were putting their objectives and their community's agenda at the forefront. So I think using those type of collaborations, being okay with, again, relinquishing power, coming from a place of intellectual humility. The other piece that can get tricky, but is developing that shared vision and mission, because folks are coming from like different disciplines and different places, but developing that will be key as well. And then the other thing that I kind of refer folks to, it might be like the Kingdom framework for for policy making, right? Like we've got to, when there's an intersection between what Kingdom would describe as like the politics stream, the policy stream, and the problem stream, that's when we can actualize true meaningful change. And that requires not just working with our community in the center, but meaningful engagement with academia and scientists who are going to create new knowledge. It's with obviously our community-based organizations. It's with health systems, particularly if those that serve the community like ours, and then the media and storytellers, right? And then when we can have that kind of marriage of all of these different institutions, then we can start to see that change as well.
Wow. So I know we only have a couple more minutes left on this panel, but I wanted to ask you sort of this final, and it has to be a fast question because we really only have 5 minutes for the panel. And I'll start with you, Dr. Christopher. So let's say we had Governor Abbott here, and the Lieutenant Governor, and the Speaker of the House, and they really, for once, they were really interested in hearing what you had to say, right? And you said, we really could change outcomes in Texas for children if we did this, and I wish you would sort of do a little bit more around this. What would, and I don't want you guys to say early education because last year the whole panel said early education, so you get to go to the next thing. So what would you say, Norm, what would be the thing?
Just as quickly as possible, we have to change the incentives that are driving investment in the hospitals and health systems so that we can flip from an illness model to a prevention and a model of engagement. It all comes down to how hospitals are paid and rewarded for the work they do.
Excellent.
It's a very narrow focus, and it's where I live.
Yeah. Steve?
I'll have a similar thing in that what gets measured drives action. And so there is very little measurement of child health in schools. And so just like we tied school funding and school administration to the standardized test scores, what if we had scores for health of children? And that would shape loose dollars and maybe have the legislature help or other agencies to try and solve the problems that we all know about.
What would happen, Steve, if you and I and others, we collaborated, we decided we're going to create a health grade for every school district? What do you think would happen in the state?
Well, we have.
Besides many superintendents being mad at us.
Well, the superintendents will be mad at us. There's no doubt about that. In fact, at one time in Austin, we published the fitness scores of Austin area schools. Oh boy, they do not like that. So, but that is one measure. It is used to say, here's how many kids are overweight, obese, or underweight, malnourished, and here's how they do on a physical activity test. The schools don't like doing it.
Right.
The politicians don't like hearing it. And so it really didn't go all that far, to be honest. Although I will say Susan Combs, when she was in agriculture, did find $20 million to give to schools to help them implement that, which is a lot of money, but not enough nearly for Texas.
Yeah.
So
I heard about it, I asked you to follow up, I'm sorry. So
it has to be made accountable.
Yeah.
These things are non-accountable. They don't even have to do them in the first place.
Yeah.
So that there's nothing that happens. So solid testing with accountability.
All right. So, hey, what are you telling the governor?
Well, if I actually met the governor, I'd probably just panic and talk about sidewalks for 45 minutes until I get down. But, if you're being honest. That's true. I mean, he probably does that. But so I will say.
Oh my word! That is wrong, Steve. That is so wrong.
But I would say that the answer I'll give here, just to add a dynamic to the conversation, is the comment that I've heard on either side of me: adverse childhood experiences. I'm going to keep this at 2 minutes.
Yeah.
You can walk in and feel a adverse childhood experience grew, in my opinion. This is as a doctor that goes from room to room to room every day of my life. You can walk in and feel the calm of a warm situation for a child, and you can walk in and feel the tension of adverse childhood experiences. I'm not saying this, it's going to sound judgmental, but I'm being honest. You don't know what the experiences were, but you know they've stacked in that room. You know that there was violence, there was drug addiction, or some combination of these things, of people coming into the house and other things like that that are not good. So I would probably take that time to say, yes, preschool, yes, Medicaid, expanding Medicaid services, but the most root cause is when a mom is pregnant or a child is a very young child in a home, figuring out both the community and the research to address and improve on Texas level adverse child experiences in these communities and studying and quantifying where those communities are most concentrated in the state.
All right, we're running out of time. Delinda,
Yes.
the governor's in front of you. One thing, what are you saying?
To address the working poor in Texas. So I was part of the working poor, working 40 hours a week, still not being able to afford to live in Texas. So of course, then we have all of those adverse childhood experiences that are associated with trauma. We're not asking them to help people that are not working or lazy. We're asking them to assist the working poor, also expecting for a living wage here in the state of Texas, mandating a living wage in the state of Texas. And lastly, because they say that they're very family friendly, but we have no family friendly policies in the workplace, and that we should mandate them in the state of Texas so moms and dads can take care of their children.
Dr. Leo, what are you thinking?
Sure, so the views here that I express are mine, and what I would say is let's work together to abolish poverty.
Yeah, very good. Look at that. So, get these guys, I tell you, when everyone has so much to say, as this group does, I do too, right? It's to be on a panel, sometimes it's painful, right? It's like, oh, I have so much to say on this. I mean, each of these people could have spoken for at least half an hour. So, no, you guys spoke for more than half an hour. Very good. So, thank you guys very much. And Mary has some
Absolutely. Again, let's give our panelists a round of applause. We so appreciate their insights and motivation to spur us on to really tackle these community problems here. So I also want to thank Dr. Bob Sanborn and Christine and Nadia for co-hosting this with us and all the amazing, tremendous work that they do for us at the state level. And then I want to thank each and every one of you for giving us half a day here, coming together across sectors. Each of you chose to come here today because you felt you have some investment in addressing social determinants of health, whatever your position is. And so I wanted to quickly talk about why we're here and what we're thinking of. There are a lot of definitions and models tied to social determinants of health and non-medical drivers of health, which quickly makes it so confusing for many people out there that are wanting to learn more about it or figure out how to address it. Each one of you plays a role in it somehow. So for us, you saw up there, and what Family Service subscribes to is the Department of Health and Human Services Healthy People Framework. Been around since 1979, and every 2 years they bring health and healthcare experts around the country together. Their mission is to improve the health and well-being of all people here in the United States. I think if you think of your own mission and what you all are working in, somehow in some fashion, you are working to improve the health and well-being of those that you serve. So you are already working to address those social determinants of health barriers and challenges. In that framework, and just as a reminder to you, there are 5 pillars, because there are many, many indicators and things tied to SDOH. But if you want a nice way to encapsulate them, first one is an economic stability, whether it's poverty, workforce development, housing insecurity, food insecurity, etc. The second one is access to high quality education from early childhood all the way through adult learning. The literacy that comes with it, everything that goes to tie to that. That third one you heard mentioned also several times is access to high quality health and health care. So many people don't have access or know how to access because of the way our nation's healthcare systems are set up. They also don't have health or nutritional literacy and everything that goes with that for them and their families. The fourth is that neighborhood and built environment. You saw how important that is to weave all of us together. And the fifth that is so critical, and I think sometimes is so less understood, and for those working in community-based orgs, this is where you also play a key role, is that social and community context or engagement. There are many, many components tied to that, but what I look at it specifically is helping people, one, to know how to access resources and where to go and not feel embarrassed or ashamed when they need those resources for them and their family. And then second, how do they then feel that they are a value contributing member of their own communities? Otherwise, they feel that social isolation and loneliness, engagement that ties to mental health, etc. All of that comes back together. And one quick example I want to give of just a small thing that ties all of these together is last year we, Family Service with Partners, hosted our first called Take a Walk on the West Side. So we're going to do one this year if you want. So it ties together all these 5 domains. We brought together families, single moms, bringing dads in who never engaged with their kids, with their young kids. So social and community engagement, bringing them together at our community center, the neighborhood place, that neighborhood built environment, helping them now to go and take a walk. We had a planned walk, a 1 mile, a 5K, or a 10K, depending on how ambitious they were, to get them out to promote physical activity and health, mental activity or health, and that social and community emotional engagement, etc., that are so often lacking out there. And we had booths and presentations to talk about all these, educating families, providing health. We showed them, and many of them lived in the neighborhood. They had no idea that it was a 2-block walk from our neighborhood place to the Greenway. And if y'all have been on the Greenway, you know how special that is for us in San Antonio. Having a chance for families to come together in ways they never do. They don't even have dinner together. They're so busy and stressed, they're not being engaged. We had them get out there. They didn't know that they had this gym on the Greenway, taking them out to Almondorf Lake or Rosedale Park, ways that they can now connect, not just within their own families in ways they had before, but now meeting other families who are struggling as well and building that sense of connection, engagement, while promoting physical, mental health, et cetera, because there's so many components to health. That is one small example, but each of you think about what are you doing to address social determinants of health in your organization, in your own lives? Who are you partnering with? Who's not at the tables that should be that's to engage in this work? Because we need to bring them in. We need to make this an inclusive effort, not exclusive, and break down all of these silos that just because we're so busy, we often don't get out of our own silos. We're using this as one more effort to bridge the health and healthcare spectrum across sectors for all of us to have a role in saying it, because that was really the only way that we will be able to move the needle forward and start breaking those what are too often intergenerational cycles. How can we leverage our strengths and our talents and be that collective voice, use those resources, do the research to show what's working and not what's not working, and then come together, because we are a special community in San Antonio. We take that for granted, but we have a lot of needs and challenges, and we have to help our families, all of us, uplift to make us better going forward. So thank you all so much for being here. We will have this event again next year, yes, and more opportunities. And I'm going to turn it over to Bob for the final closing remarks. Thank you again.
Right, thank you very much, Mary. So very, very briefly, I thank Mary so much for the partnership with Family Service, and we love coming to San Antonio and talking about this stuff. I thought one of the key things, one of the questions asked today was around collaboration. And don't wait for someone to ask you to collaborate with them. You need to lead. You need to ask people to collaborate. And when I think about great collaborations, you know, it's reaching out, and it's not just saying we need to change the world. It's developing a relationship. I feel like Mary and I are good collaborators, but part of the reason for that is that we try to have happy hour as often as, because we both like a cocktail, right? So, but I think having coffee with people, developing a relationship to be those collaborations, to have those collaborations is very, very important. And I really encourage, you know, there's not enough collaboration in the state of Texas. And it's up to you guys, right, to say, I'm going to collaborate, I'm going to bring some people together, I'm going to make it happen. So I want to thank you very much. I want to thank the whole team from Family Service for the great work that they've done. And we'll let you guys go, but first, for children. Thank you all very much. Have a safe night. Survey, do your survey, guys.
All the people.